It's my pleasure to be here today to speak on the topic of new treatment options for people living with HIV in the aspect of pediatric and adolescent. I'm Dr. Thanyawee Puthanakit. I'm a pediatric infectious disease specialist based in Chulalongkorn University in Bangkok, Thailand. So for the outline of my talk, I would like to begin with a global update of pediatric and adolescent HIV, and then talking about new treatment options for newborn, infants, children, and adolescents. It's very exciting because in the last couple of years, there are new treatment options, formulations that is addressing special needs for newborn infants and children. And the last topic is what's on the horizon. So begin with the global updates of kids living with HIV. This number showing about how many children born with HIV in each year. And on the left-hand side, you're showing that the target of mother-to-child transmission prevention, we aim to reduce number of transmission to around only 40,000 per year. However, in 2019, about 150,000 babies still born each year. It means that there are a need for treatment for newborns and infants because we have early infant diagnosis, and now we can diagnose baby during the first weeks or first month of life. So therefore, they are in need of special formulations or special treatment for infant. And the second part is on the number of HIV children living with HIV that was on treatment. There are about 1.4 million targets to provide ART. However, we are still missed the target, only about 1 million living with HIV. Therefore, we still need a lot more on the first-line regimen for children who are not already on treatment. In terms of plasma HIV viral load suppression, is the surrogate marker for successful of the treatment, in which in adult, the target is more than 90% of adults living with HIV can have viral suppression after received ART. However, in pediatrics population, we still not reach that goal. This data showing from UNAIDS showing that among children living with HIV receiving ART, only about 70% had viral suppression comparing to adult. Why it's happened like that? There are many challenges in pediatric and adolescent HIV treatment. For example, there are limited formulations for pediatrics. Children rely on adults in providing ART. And also there are developmental change over time from infant to children and adolescent. Therefore, there are several factors that make pediatric and adolescent HIV fall short from the target of HIV viral load suppression, which means that we need more and appropriate treatment to help pediatric populations to reach a target of 90% viral suppression. And this slide showing the DHHS guideline from the US to address the first-line ART for pediatric treatment. The guideline is just updated in April 2021. And in the slide, you can see that there are many details in which starting from birth to 14 days, because in this period, there are different physiology in terms of drug metabolism. Therefore, birth to 14 days, we're starting using nevirapine as a main drug. Now we have Rotavir, which I will tell you more in details of how to use Rotavir in infants. And 2 to 4 weeks recommended is Lopinavir or Rotavir. And 4 weeks to 3 months is the Rotavir disposable tablet. 3 months to 3 years, the Rotavir disposable tablet. 3 to 6 years, the Rotavir in disposable tablet, or if body weight is above 20 kilograms, can use adult formulation. And if above 6 years, recommended is dolutegravir or bictegravir. So it's so exciting that integrase inhibitors that has been first-line regimen for adults, now there are some certain formulations or certain drugs that can be used in the whole spectrum of pediatric to adolescent HIV. However, there are some details of formulation and dosing that I will tell you in further slide. In terms of alternative regimen, in 4 weeks to 3 months, can use Lopinavir, which this one is the mainstay of treatment in pediatrics, Lopinavir oral solution. However, there are also challenges of Lopinavir oral solution, which is composed of alcohol and also bitter taste, and also have to keep in the refrigerator. So when we have dolutegravir that can be used in this population, it's very useful. And then for age 3 years and above, they can use many formulations similar to adult. However, there are still limited dosage recommendation in each body weight band or each age group. For example, ripivirine that can be used in adult can be used in pediatrics if body weight is above 35 kilograms, or elvitekivir if body weight above 25 kilo. So you can see that it's quite complicated when we have to address young children and adolescents in different age or body weight. In terms of 2 NRTI backbone, in young infants, the mainstay is cedarvudine and lamivudine. And when they're age older, above 3 months, can use abacavir and lamivudine. And TAF, which is recommended for adult, can be used in pediatrics if body weight above 25 kilograms. So I would like to address in details of integrase inhibitor use in different age population. The first one is rotavir granules. It's approved to use for newborns, the full term with body weight above 2 kilograms. Why it's quite complicated in rotavir? Because rotavir is metabolized by UGT1A1, which have dramatically increased activity over the first week of life, meaning that in the first 7 days of life, the dose have to be very minimal. In the slide, you can see that in the first week of life, recommended only 1.5 milligram per kilo once daily. And after that, when the metabolite is kicked in, we can increase the dose to 3 milligram twice daily, and then 6 milligram twice daily after 4 weeks. And the second point is that rotavir and bilirubin metabolized by UGT1A1, which can compete with albumin binding site. It have to be careful for newborns, which has problem with hyperbilirubinemia or kernicterus. Therefore, the first few days or week have to be careful on the metabolism. And also, if mother received rotavir, there are some washout period in infant. So if mother received rotavir, infant can delay the first dose to 12 to 60 hours after delivery. And in the slide is the data from IMPACT P11110, showing that this recommended dose can keep trough target above 33 nanogram per ml, and the Cmax is not too high. So this is the recommended formulations and a dose for newborns and infants. However, in reality, how to use it, it's quite complicated. And the mother need to mix rotavir granule as shown in the slide, mix into the bottle, and then mix it and titrate it and keep it to the newborns. And how to titrate, it's quite also very tedious. From each body weight band have to titrate dose per dose and give it twice daily. Therefore, it's innovation, and it's interesting to have rotavir granule available. However, it still need to be find out how to use this in resource limited settings like in Asia or in Africa. Another one is on the lopinavir ritonavir 4-in-1, or called Quadrimune. Lopinavir oral solution is a mainstay for treatment for children less than 3 years of age, because efavirenz cannot have easily optimized dose. However, lopinavir oral solution have to be keep refrigerated, in which is not practical in the field. And DNDi developed Quadrimune, which is the abacavir, lamivudine, and lopinavir ritonavir in granules that can be used for children at body weight 3 to 25 kilos, which is, it's very interesting, and it will be help in terms of the access for young infants. And also the cost is also affordable at less than $1 per day. Then I would like to shift on the dolutegravir in children. The dolutegravir dosage has been studied in many settings, such as in the IMPACT study and also in the Odyssey study, which is a large trial in Africa, Europe, and Asia, including in Bangkok, Thailand, to see the dose optimization for pediatrics population for both first line and second line. I would like to show on the first table is on the dosage for the dolutegravir dispersible that can use down to 3 kilograms of baby. And also for body weight above 20 kilograms, can use the dolutegravir 50 milligram film coat tablet similar to adult. Therefore, if body weight above 20 kilo, can use adult formulation. But if younger, need to use the dolutegravir dispersible tablet, which now it's approved and provided through PEPFAR programs. And also the single tablet regimens is also very important for older children and adolescents. So if the dolutegravir combined with TAF, FTC, it can be used for a child who body weight above 25 kilograms. But if it combined with tenofovir 3TC, it have to wait until body weight above 35 kilograms. In terms of the dolutegravir dispersible tablet, this one is very helpful because it have a generic dolutegravir dispersible tablet in a size of 10 milligrams that can be cut in half. Therefore, it can be used easily down to body weight 3 kilograms as shown in the table on your right-hand side. For example, 3 to 6 kilograms can use half tablet of dispersible dolutegravir tablet. And also the pricing agreement is affordable because it's launched at a yearly cost of only $36 per child. So I think dolutegravir will be the one that have a game changer for pediatric population around the world, especially in resource-limited settings. However, dolutegravir also have a concern if it's used in adolescent. There are two studies that I would like to address. The first one is on the concern of increased body weight, especially in women or adolescent girls. This is a study showing from the US, showing that in adolescents who change to use tenofovir 3TC and dolutegravir, there are quite a significant change in body weight after their follow-up, especially in female. So therefore, this also need to be keep an eye on when dolutegravir is used in a wide scale in adolescents around the world. And the second one is on the risk of neurotube defect because adolescents may be pregnant, and updated data showing that the risk of neurotube defect if using dolutegravir at conception is around 0.3%, which is about 3 times higher than non-dolutegravir ART at conception. However, this is not a limitation for adolescent girls to use dolutegravir. However, it's recommended to have contraception or using folic acid if would like to conceive. In terms of adolescent using integrase inhibitors, one of the issues that have a big concern is on tuberculosis, because tuberculosis is also common during adolescent period. Therefore, integrase inhibitors might need to be used with rifamycin or rifampicin for treatment of TB. So in this line showing that if the dolutegravir or bictegravir will be used in combination with rifampin, it have to increase the dose to twice daily, which this one is quite different from ephedrins that has been used in the past in middle income country or in resource limited settings where they have a lot of tuberculosis. But ephedrins not need to have dose adjustment. But if we use dolutegravir or bictegravir, have to increase the dose for drug interaction with rifampin. This one is also details of how to use with rifampin. Another one is on bictegravir. Bictegravir is also recommended for children above 25 kilos and but older than 6 years old. But there are also studies presented at PROI showing that if age more than 2 years and body weight around 14 to 25 kilograms, can use low dose, fixed dose combination of bictegravir, FTC, and TAF, which is quite in a smaller pill and can be used as a once daily single tablet regimen. So it's very exciting that all of this development now have a formulation and dose that optimize down to a younger and younger child. And another approach is on 2 drugs regimen, which has been used in adult. They also have a investigational study, a clinical trial in adolescent, for example, using dolutegravir 3TC for ART suppressed adolescent and also adolescent naive, newly infected first-line regimen in adolescent 12 to 18 years. And where we look forward to having data more, because this one will be smaller pill and also have lower side effect because using only dolutegravir and 3TC without TDF or TAF, or other regimen that is have ongoing studies such as doravirine with islatravir that has been in investigational protocol for adolescent naive, which is very interesting because islatravir has a long acting and hopefully it have more forgiving for adolescent that might sometimes miss the dose in order to have viral suppression and not create drug resistance. And another component that is very important is that for example, in Thailand, when we have ART treatment for about almost 20 years, but early days when the child had exposed to not optimum ART at that time, for example, dual ART, dual NRTI, or have early generation of protease inhibitors. Sometimes we also have multiclass failure. For example, in this case, there's perinatally acquired HIV that have go through many regimens. And earlier this year, he presented with low CD4 less than 200, and had plasma viral load is 14,000, and have multiclass resistant mutation. And luckily, we can enroll him into new formulations, Rotavir for capsid inhibitors to treat multiclass failure. So this one is just example of how we need also the new drugs for multiclass failure, adolescent and young adult, in order to have an optimized regimen. And in terms of long-acting antiretroviral drugs, I think it's very important for both child with multiclass failure, ART failure, and also with adolescent who are maintenance treatment, because during adolescent period, there are about 10% of them have viral rebound because of adherence problem during adolescent year, when there are so many things going on in life. So we're thinking about how adolescent will accept long-acting antiretroviral. This data is presented from US site that survey about interest of the adolescent to long-acting antiretroviral. It's interesting to showing that adolescent also prefer to have long-acting antiretroviral injectable, but it have to be at least once every month or every 3 months. And they also have a little bit concern about potential side effects. And the patients who have high viral load is more interested in long-acting antiretroviral drugs, which it makes sense because it might be easier for them to comply to regimen and be able to achieve ART. So we're looking forward to have a long-acting antiretroviral rollout or more study in adolescent populations. So I would like to conclude that new treatment options for pediatric and adolescent living with HIV is very important. In the last few years, we see more and more a need for a regimen for infant and young children, because the better of early infant diagnosis using HIV DNA PCR, we can diagnose infant very early in their first few months of life. Therefore, we need regimen that's specifically for the first year of life, which now have both Rotavir and dolutegravir that go down to a baby body weight as low as 2 to 3 kilograms. However, with young children, it's also urgently needed in a scale of widely available, especially in middle income and resource limited settings. In terms of adolescent, we are looking for simplified maintenance regimen in order to be friendly for adolescent and help them go through adolescent period, either long-acting oral regimen like islatravir or long-acting injectable drugs. And also, it's very important, it will be life-saving regimen, ART for multiclass failure adolescent living with HIV, especially the perinatally infected child who go through many regimens in their childhood. So I'm very hopeful that in the futures, we will have more pediatric ART that is available, accessible throughout the world, not only in North America or Europe, but also including in Africa and Asia. Thank you.